Hello everyone. Today we are starting the epidemiology and the first lecture we will be covering the basic concepts of epidemiology. So what is epidemiology? It's derived from the word epidemic, in which epi means among, demos means people, logos means study, and this is very old word and dating back to some 3rd century BC. So what are the definitions of epidemiology? In 1873, Parkin said that the branch of medical science which treats epidemics is epidemiology. In 1927, Frost said that science of the mass phenomena of infectious diseases is called epidemiology. In 1934, Greenwood came with the definition that the study of any disease as a mass phenomena is called epidemiology. And in 1960, McMahon gave a refined definition that the study of the distribution and determinants of the disease frequency in man is called epidemiology. At present, epidemiology has been defined as the study of the occurrence and distribution of health related events, states, and processes in specified populations, including the study of the determinants influencing such processes and the application of this knowledge to control relevant health problems is called epidemiology. So you can see there are many words used: study, occurrence, distribution, health related events, states, determinants. So let's see what these words means. Study. Study includes surveillance, observation, screening, hypothesis testing, analytic research, experiment, and prediction. Distribution refers to analysis by time, place, and population, for example, classes or subgroup of persons affected in an organization, population, or society, or at regional and global scales. Determinants are the geophysical, biological, behavioral, social, cultural, economic, and political factors that influence health. And the health related events, states, and processes include outbreaks, diseases, disorders, causes of death, behaviors, environmental and socio-economic processes, effects of preventive programs, and use of health and social services. Specified populations are those populations with common contexts and identifiable characteristics. Application to control makes explicit the aim of epidemiology to promote, protect, and restore health and to advance scientific knowledge. The diseases included in the subject matter have increased from those which occur in epidemics to include those infectious diseases which are endemic in nature, and more recently, chronic diseases, accidents, and mental health. Modern epidemiology has also taken within its scope the study of health related states, events, and facts of life occurring in human population. This includes the study of the health services used by the population and to measure their impact. Epidemiology is often more concerned with the well being of society as a whole than with the well being of individuals. Although there is no single definition to which all epidemiologists agree, but there are three components which must be dealt in the definition. The number one is frequency, study of disease frequency. Second is studies of the distribution of that disease or any event. And third is studies of the determinants. So let's see what are these. Disease frequency. Measurement of frequency of disease, disability, or death, and summarizing this information in the forms of rates and ratios like prevalence rate, incidence rate, death rate. So rate and ratio is the basic measure of the frequency, disease frequency. These rates are essential for comparing disease frequency in different populations or subgroups of the same population in relation to suspected causal factors. Such comparisons may yield important clues to disease etiology. This is vital step in development of strategies for prevention or control of health problems. Equally, epidemiology is also concerned with the measurement of health-related events and states in the community, like health needs, demands, activities, tasks, healthcare utilization, and variables such as blood pressure, serum cholesterol level in the community, height in the community, weight of the community, etc. In this respect, epidemiology has the feature of quantitative science. So, from disease frequency we get quantitative science. Then second is the distribution of disease. Disease is not uniformly distributed in human population. The basic tenet of epidemiology is that the distribution of disease occurs in patterns in a community and that the patterns may lead to the generation of hypotheses about causative or risk factors. So, epidemiology studies these distribution patterns in the various subgroups of the population by time, place, and person. That is, the epidemiologist examines whether there has been an increase or decrease of a disease over a time span, whether there is a higher concentration of disease in one geographic area than in others, whether the disease occurs more often in men or in particular age group, and whether most characteristics or behavior of these affected are different from those not affected. An important outcome of this study is formulation of etiological hypothesis. This aspect of epidemiology is known as the descriptive epidemiology. So, distribution of disease gives us the descriptive epidemiology. And the last one is the determinants of the disease. A unique feature of epidemiology is to test etiological hypotheses and identify the underlying causes or risk factor of the disease. This requires the use of epidemiological principles and methods. This aspect of epidemiology is known as the analytical epidemiology. So, determinants give us the analytical epidemiology. Analytical strategies help in developing scientifically sound health programs, interventions, and policies. So, what are the aims of the epidemiology? According to International Epidemiological Association, there are main three aims. Number one, to describe the distribution and magnitude of the health and disease problems in human population, to identify etiological factors or risk factors in the pathogenesis of the disease, to provide the data essential to the planning, implementation, and evaluation of services for the prevention, control, and treatment of disease, and to setting the third one is to provide the data essential to the planning, implementation, and evaluation of services for prevention, control, and treatment of disease, and to the setting up of priorities among those services. So, these are the three main aims of the epidemiology. In order to fulfill these three aims, we require type of studies, and they are mainly three types. One is descriptive studies, second is analytical studies, and third one is the experimental or interventional studies. The ultimate aim of epidemiology is to lead to effective action, like to eliminate or reduce the health problem or its consequences, and to promote the health and well-being of the society as a whole. So, what is the basic difference between epidemiology and clinical medicine? The basic difference between epidemiology and clinical medicine is that the epidemiology, the unit of the study is the defined population or population at risk. In clinical medicine, the unit of the study is the case or the cases. So, epidemiology is thus concerned with both the sick and healthy. It has been stated that clinicians are interested in cases with the disease, the statistician with the population from which the cases are derived, and the epidemiologist is interested in the relationship between cases and the population in the form of a rate. Clinical medicine and epidemiology are not antagonists, and both are closely related, coexistent, and mutually helpful. Epidemiological approach to any health problem or a disease, and this is based on two foundations. Number one, we ask questions, and second, we make comparisons after gathering the information. We ask questions. Epidemiology has been defined as a means of learning or asking questions and getting answers that lead to further questions. For example, when we ask questions related to health events, what is the event, means what is the problem, what its magnitude, where did it happens, when did it happens, who are affected, why did it happen, and when it's asked in relation to action, what can be done to reduce this problem and its consequences, how can it be prevented in the future, what action should be taken by the community, by the health services, or by other sectors, where and for whom these activities to be carried out, what resources are required, how are the activities to be organized, what difficulties may arise, and how might they be overcome. Answer to the above questions may provide clues to disease etiology and help the epidemiologist to guide planning and evaluation. Then, after asking the questions, or we make comparisons. The basic approach in epidemiology is to make comparisons and draw inferences. This may be comparison of two or more groups, or one group having the disease or risk factor and the other groups not having the disease or risk factor, or comparison between the individuals. By making comparisons, the epidemiologist tries to find out the crucial difference in the host and the environmental factors between those affected and those who are not affected. Clues to etiology come from such comparisons. One of the first consideration before we start making the comparisons, we must ensure that those groups we are comparing or the individuals which we are comparing, they have the comparability. In other words, those both groups should be similar so that like can be compared with the like. For facts to be comparable, they must be accurate and they must be gathered in a uniform way. For example, the study and control groups should be similar with regard to their age and sex and similar other pertinent variables which you are taking in the consideration, which you are going to measure or for which you are looking after the answer. The best method of ensuring comparability in such cases is by randomization or random allocations. Where random allocation is not possible, as in case control and cohort study, but is known as matching is done for selected characteristics that might confound the interpretation of the results. Another alternative is standardization, which usually has a limited application to a few characteristics such as age, sex, parity, etc. So, what are the basic measurements in the epidemiology? The measurement of mortality and morbidity in human populations. The first requirement is therefore definition of what is to be measured and establishment of criteria or standards by which it can be measured. So first we have to decide that what we have to measure, and we have to lay down some standards that by which it can be measured. The clinician may not require a precise definition of disease for immediate patient care, but the epidemiologist needs a definition that is acceptable and applicable to its use in large population. that is precise and valid to enable him to identify those who have the disease from those who do not have the disease. Clear definitions help to minimize errors in classification of data. The scope of measurements in epidemiology is very broad and unlimited, and the following may be included for measurements in epidemiology. The measurement of mortality, we have to measure the morbidity, disability, measurement of natality, measurement of the presence or absence or distribution of the characteristics or attributes of a disease, measurement of medical needs, healthcare facilities, utilization of health services, and other health related events, measurement of the presence or absence or distribution of the environment and other factors suspected of causing the disease, and measurement of demographic variables. So to measure these parameters or these which we discussed, we need to understand few terminologies. So first, what is variate? Any piece of information referring to the patient or his disease is called a variate. A variate can be discrete, that is, it can be present or absent. For example, lung cancer present or absent, leg broken or no, rash in measles yes or no, or it can be continuously distributed like blood pressure, serum cholesterol values, and height and weight, because they are different for different people. Then circumstance. Any factor in the environment that might be suspected of causing a disease, for example, air pollution, polluted water, etc. The epidemiologist usually express disease magnitude as a rate, ratio, or proportion, which we discussed earlier. That these are the basic measures of measurement in epidemiology. A clear understanding of the term is required for proper interpretation of epidemiological data. So, the basic tools of measurement in epidemiology are rates, ratios, and proportions. So, what is rate? Let's have an example. When we say that 500 deaths from a motor vehicle accident in a city A during 2010, so it's just nothing more than the counting deaths in that city during the particular time. Such a statement may be sufficient for the municipal administrator to provide necessary health services. But when you are epidemiologist and when you compare one city with another city, this simple information will not help. To allow such comparisons, the frequency must be expressed as a rate. So we required some calculation that city A is much better than the city B. So to answer this question, we have to calculate the frequency. A rate measures the occurrence of some particular event, development of a disease, or the occurrence of a death in a defined population during a given time period. It is a statement of the risk of developing a condition. It indicates the change in some event that takes place in a population over a period of a time. For example, death rate. So death rate is defined as number of the deaths in 1 year divided by mid-year population into 1000. A rate comprises the following elements. We saw numerator, denominator, time specification, and the multiplier. The time, usually in the rate we use calendar year, but it can be month. The rate is expected for either 1000 or some other round figures like 10,000 or 1 lakh. These are selected according to the convenience or convention to avoid fractions. The various categories of rates are crude rates. These are the actual observed rates such as birth and death rates. Crude rates are also known as unstandardized rates. Specific rates. These are the actual observed rates due to specific causes like tuberculosis or occurring in a specific age group, example age group of less than this, or sex groups, or during specific time period, for example annually, monthly or weekly. Standardized rates, these are obtained by direct or indirect method of standardization or adjustment, for example age, sex. Then comes the ratio. So it expresses a relation in size between two random quantities. The numerator is not the component of the denominator. The numerator and denominator may involve an interval of time or may be instantaneous in time. The numerator and denominator may involve an interval of time or may be instantaneous in time. Broadly, ratio is the result of dividing one quantity by another. So it is expressed like x divided by y. For example, the ratio of white blood cells relative to red cell is 1 ratio 600 or 1 by 600. This means for every white cell we have 600 red cells. And other examples of ratios are sex ratio, doctor population ratio, child woman ratio, etc. The third one is the proportion. A proportion is a ratio which indicates the relation in magnitude of a part of the whole. The numerator is always included in the denominator and it is expressed in percentage. For example, number of students with scabies in hostel divided by total number of the students living in that hostel in same time and multiplication by 100. So, what is numerator and denominator? Numerator refers to the number of times or event, for example, sickness, birth, number of deaths, number of episodes of sickness has occurred in a population during a specific time period. Numerator is a component of the denominator in calculating a rate but not in a ratio. Denominator, the lower portion of a ratio. Numerator has little meaning unless it is related to the denominator. The epidemiologist has to choose an appropriate denominator while calculating a rate. So it may be related to population or related to the total number of the events. So when it is related to the population, the denominators related to the population comprise the following. The mid-year population, because the population size changes daily due to births and deaths and migration, the mid-year population is commonly chosen as a denominator. So mid-year population is referred the estimate as on the 1st of July of any year. And this is a important question, Viva questions you will be asked by the examiners when that what is the mid-year population. Population at risk. This is an important concept in epidemiology because it focuses on groups at risk of disease rather than an individuals. The term is applied to all those to whom an event could have happened whether it did or not. For example, if we are determining the rate of accidents for a town, the population at risk is all the people in the town. But sometimes it may be necessary to exclude people because they are not at risk. For example, in food poisoning, only those who ate the food are at risk of becoming ill. Similarly, in calculating general fertility rate, the denominator is restricted to women of childbearing age 15 to 49 years. Older women and little girls are excluded because they are not at risk of becoming pregnant. In short, population at risk is restricted solely to those who are capable of having or acquiring the disease or condition in question. Then third one is the person time. In some epidemiological studies, persons may enter the study at different times. Consequently, they are under observation for varying time periods. In such cases, the denominator is combination of persons and time. The most frequently used person time is person years. Sometimes this may be person months, person weeks, or man in hours. For example, if 10 persons remain in the study for 10 years, they are said to be 100 persons year of observations when we are calculating. The same figure would be derived if 100 persons were under observation for 1 year. These denominators have the advantage of summarizing the experience of persons with different duration of observation or exposure. Then the next comes person distance. A variant of person time is person distance, as for example passenger miles. Subgroups of the population. The denominator may be subgroups of a population, for example age, specific sex, specific occupation, specific social class, etc. Then related to total events. In some instances, the denominator may be related to total events instead of the total population, as in the case of infant mortality rate and case fatality rate. In the case of accidents, the number of accidents per 1000 vehicles or per million vehicle miles will be more useful denominator than the total population. Many of them may not be using the vehicles. So we finishes the first lecture, and I am sure that there must be lot of questions arising in your mind that what this topic is. But whatever we covered today, we are going to repeat this everything in the coming lectures, and we will be covering each and every aspect which we covered today in the next lectures in detail. This topic is very important, and coming lectures which are in few weeks will be delivered are also very important, because when you pass out as a MBBS graduate and start working in the field, most of the time you are doing the epidemiological works. You will be calculating the rates on weekly basis, you will be submitting your reports. Unintentionally, you will be doing this epidemiological work in the field most of the time. This topic is important for your examination point of view and for your future also. This will be helpful for you in longer run. If you have any queries, you can mail me at akshay@healthandfamily.in. You are requested to subscribe the channel, YouTube channel, so you get all the lectures in the coming weeks. And thanks for listening. Have a nice day.